Welcome, welcome, welcome. I'm delighted to see you all this evening. It's dark, but it's not late. It's winter. So this is kind of the end of the year. We always do something a little special in our two programs, Partnership with Health and Menu for Change. And we have kind of this theme going on, and you probably know the theme's cancer. Now, most people don't feel good when they hear the word cancer, but there's a lot of positive energy we're going to kind of vibe tonight. And we have a couple of speakers and opportunities to ask questions as well. You'll notice at the back of the room there's a bunch of handouts, and you want to make sure to get some of those on your way out. And I'd like to introduce the first speaker, and some of you may know him. It's Dr. Ames Smith. Dr. Smith is a breast surgeon extraordinaire. He's going to give a little bit of his bio, so I won't steal his lines. But he is the medical director of a hereditary cancer risk clinic here at the Polyclinic, a fabulous breast surgeon. I definitely know that personally. And he's going to kick off the talk, and then we're going to kind of segue to our next speaker. So welcome, Dr. Smith.
Thank you. Well, thank you so much for inviting me, and I'm delighted to be here. So I am a little bit about my background. I am a surgeon. I was trained from 1984 to 1990 at Baylor College of Medicine in Houston under Dr. Michael Levinsky, if anybody's ever heard of him. And I've really enjoyed my surgical career. I started private practice in 1990, and I was in practice in a small group, surgical group situation in Austin, Texas for 22 years, and then had a huge opportunity open up here at the Polyclinic, and I just love being here. It's been just a wonderful, amazing opportunity. But of all the things I've ever done in my career, the thing by far that I love the most has been the work we've done in the hereditary cancer risk detection and screening and prevention realm. And this is something that's really is more of a mission than anything else, because it's trying to help our doctors in the Polyclinic, but even more broadly, just people out there in the general public, helping them realize how much of an issue this is and how life-saving it is if we just recognize it. So, but for tonight, really what I wanted to do is just go through a few key things and definitely tap into my experience as a surgeon, and to help you kind of understand specifically risk factors for breast cancer, which is the #1 cancer for women. And then also understanding screening guidelines. There's so much confusion out there right now about just general screening guidelines. There's no confusion with me, so hopefully you'll be less confused after tonight. But then the other thing is just to go through just some very basic thoughts about genetics so you understand these things. And also looking for patterns so that you can recognize these in other people, other families. You may be in casual conversation and hear somebody talking about something, and that could be a clue that could save their life. And then just some basic thoughts about preventive therapy, both medical and surgical, and then some evolving aspects. Yeah, it's really exciting, some things that are really on the horizon that Dr. Baumgaertel is aware of and we'll be collaborating on. So anyway, we'll dive in. So in terms of risk factors, there are a whole bunch of different risk factors. And I like to think in terms of minor and primarily minor and major risk factors. And also there are some things that specifically to focus in on as an encouragement would be things that you can actually do that can lower your risk and also improve quality of life. And again, big kudos to Dr. Baumgaertel because she's on the forefront of that. So everything she's doing through Menu of Change is actually helping in the realm of cancer risk reduction. So, but early age menarche, having no children or greater than 30, first, age for first child, not breastfeeding, menopause after 50, second or third degree relatives with breast cancer, 5 years of hormone replacement therapy, especially combined hormone replacement therapy, obesity, inactivity, alcohol. Those are relatively minor on the spectrum. So in terms of risk, some of those are modifiable. So definitely, I'm a big encourager. So with my patients that I see, I'm just always encouraging them to really try to adopt a healthy lifestyle. And but those are not major, but every little bit helps. So things that would be more moderate risk, and these could increase the risk by 4 times the usual risk for somebody that doesn't have these, would be things like atypical hyperplasia. If you don't know what that is, then you probably have never had a biopsy, and that's good. So, but this atypical hyperplasia is just a finding that we might see based on a mammogram that showed an abnormality leading to a biopsy, and then atypical hyperplasia would be diagnosed. And so basically, if we see that, the main thing that clues me into is that that particular woman may benefit from, number one, being sure that she gets her annual mammogram, but she might benefit from risk-reducing medication. And so first-degree relative, especially if they're less than 50, having a first-degree relative essentially doubles the risk for breast cancer. Here's the thing, though. In my practice, I tell patients that philosophically, I'm trying to throw fear out the window and throw any anxiety out the window. Having risk does not mean inevitability. It just means these are people that, the great thing about what I deal with is most of the time we can catch it early if it's going to happen, or we can even prevent it. So it's a realm where it's very upbeat because we're doing things proactively to set things up right so we don't have to deal with some of these really bad situations. But if somebody has a first-degree relative with breast cancer, that's somebody, again, that I just advise them to be a self-advocate and write down on their calendar, last September is when I had a mammogram, next September I'm going to get a mammogram. It doesn't matter if anybody notifies you or anything like that. It's just good, good self-advocacy. So prior breast cancer, that is certainly a risk factor for the possibility of developing another one. Age greater than 60, so basically as we grow older, definitely there is an ongoing increased risk. And then breast density, we'll talk about that in a little bit. So this is a major focus of my practice, is high risk, because these are things that really go beyond any of the risks that we've already talked about. This is like 10 times the risk of somebody without this risk factor. And BRCA1 and BRCA2 are common ones that you would have heard about. Angelina Jolie had a BRCA2 mutation. But these are inherited mutations that are passed down either through the father's side or the mother's side. They're not linked to the X or the Y, so they are autosomal, chromosomal mutations. So, and a lot of people don't think about that, but again, from the mother or the father. Chest radiation therapy, usually for Hodgkin's disease, in young patients, that is also a high risk factor. And then LCIS, which is lobular carcinoma in situ, is something that we consider a high risk factor. And any of these, if you have questions about it, we can come back to it later. There is a lot of confusion about mammographic guidelines and when to screen, and I think it's very interesting. The U.S. Preventive Service Task Force, which is really the agency that came out with the recommendation to start screening at age 50 every other year for an average risk woman. It's very interesting if you look at the composition of the panel, and I read every document multiple times and really studied it and thought about it, but there are no treating physicians on that panel. There are no surgical oncologists, there are no radiation oncologists, there are no medical oncologists. And if you read some of the fine print of the work that they did, they talk about, well, that the mortality risk reduction for women in their 40s is not that great. But the problem is the women that I see that are in their 40s that are dying of breast cancer, for them, that was a big deal. And so there's a range of guidelines. I tend to favor the American Society of Breast Imaging and the American College of Radiology. I tend to favor starting screening mammography at age 40 annually. And I'm always so excited when I hear back from primary care patients. I ask, what did your doctor recommend? And they say, oh, start at age 40. It's like, yes, I'm going to give them a pat on the back. And anyway, I actually went on a local television station in Austin and spoke out very vocally that it should be age 40. Disregard what those other people were saying. And I'll show you some examples. I've actually collected a bunch of examples of women in their early 40s that were diagnosed with early stage breast cancer that if they had waited, they would not be with us right now. So I feel strongly about that. This is the National Comprehensive Cancer Network. This is another big agency that issues guidelines, and this is the one that we cancer treating doctors really believe in. And you can see for average risk, age greater than or equal to 40, annual screening mammography. So anyway, one of the big harms that they were talking about related to mammography has to do with false positives. And so we all recognize that that's an issue. In just all of the patients that I've talked to, and I've been doing this now almost 3 decades in private practice, so I've met and dealt with and treated many, many women, and the vast majority, I would say, have been less concerned about false positives than they have been about missing cancer. And especially when you consider that if you look at the #1 causes of death in the age 40 to 50, breast cancer is pretty high on the list. So, if you consider that 100 women with a screening mammogram, 90 would be told their mammogram is normal, 10 would be asked to return for a additional mammogram or ultrasound, 6 after that additional study would be told everything's fine, 2 would be asked to return in 6 months for a follow-up exam, and then 2 would be required to have a needle biopsy. And some of those needle biopsies would be benign. So, and ultimately, everybody can decide for themselves what they want to do. This was just one example I just wanted to show you. This is a woman, age 43, that came in with a palpable mass, and she was told by her doctor, oh, just wait till you're 50. And the problem is, she has late-stage breast cancer, and this could have been avoided if she had started at age 40. And I see a lot of these women, so I'm biased on this. I declare that. So, breast density. How many of you are aware of density, or is that becoming, have you kind of noticed a change in that, or are people starting to talk about that a little bit more? Well, essentially, the deal with density is there is now a new law in Washington State that requires notification by your doctor of what your density is. And the reason is ultimately is that there was a woman at one point who had very dense breast tissue that wasn't aware of the fact that mammograms can miss things. So every patient I see, I have the same discussion, but basically mammograms are not perfect. Mammograms can miss about 15% of breast cancers. And you can imagine breast cancers are whitish on mammogram typically, or sometimes they may have calcifications. But as you go from a very not dense situation to an extremely dense situation, this has a pointer.
It's very top.
This one right there. Oh, okay, got it. Okay. You can see that it would be very easy for breast cancer to hide in there. So our current thinking is that in the extremely dense situation, that's also an independent moderate risk factor for breast cancer. So it's kind of a double whammy because things can be missed and it's also an increased risk factor. So now on your mammography report, you will always have on there, and you'll get in a letter to, about your mammogram, what your density is. And again, this would be fatty density. The fat density looks kind of blackish. This is scattered fibroglandular density, which just means like these little scattered islands of density. This is heterogeneously dense, which means that essentially 50 to 75% of this surface area This cross-sectional area is whitish, and then that's extremely dense. So, and one thing along those lines just to mention is that there is, in some cases, an option for supplemental screening in that setting with density. Generally, we don't do screening ultrasound because there are too many false positives with screening ultrasound. Generally, if they find an abnormality on mammogram, that may lead to an ultrasound, or if a patient presents with a symptom like I feel a mass or I have a discharge or that type of thing, they might do a supplemental ultrasound, but we don't do that in every case. It is very important when you go in for a screening mammogram, if you're having a symptom, to report that, okay? Because screening mammograms, as I've just said, can miss things, but if you're having a symptom when you go in there, like, boy, I feel something right there, then they're going to convert that from a screening to a diagnostic, and in that setting, they would do an ultrasound too. In some cases, we consider screening MRI. Screening MRI, though, generally the insurers will not pay for a screening MRI based on density alone. So screening MRI, the indications for doing that would be if it's a high-risk situation. So if you have a strong family history or you have some of these other risk factors, there are times where we could get you to a level of risk. We actually do risk calculations where we might be able to do screening MRI. The thing about MRI is that it's a very high-tech, wonderful technology. It uses electromagnetic fields, and by far its greatest pro is that it's very sensitive and it won't miss things, especially in an extremely dense situation. But it also is not a perfect test, and it also has false positives. And so the whole idea about supplemental screening would ultimately go back to your primary care. You know, you could talk with them about it. A big part of my practice is risk assessment and management and trying to develop care plans given all these different factors. So I'm always happy to see somebody if they, even sometimes I'll see patients for that indication alone, just I have really dense tissue, what do I do? So there are good, thoughtful approaches for all those things. But in general, just based on having extremely dense tissue, it's reasonable just to have annual mammograms, but make sure that it's annual. Don't skip a year. Okay, now, a big focus, and probably one of the primary focuses, apart from just my surgical practice of doing cancer surgery and also risk-reducing surgery, but is screening for possible hereditary risk. And so we're going to dive in a little bit further on that. About 5 to 10% of cancers are hereditary. And what I mean by that is just that there is a mutation in the DNA that can be passed on to offspring. Most of these are autosomal dominant, and what that means is just that we all have a copy of DNA from our mother and a copy from our father, and it's intertwined in these amazing double helixes. And I'll show you a nice picture in a little bit. But with autosomal dominant, it just takes one mutation from either the father or the mother, and that's going to show up. There is high penetrance with these, which just means that if somebody has a mutation, the likelihood of having that show up in terms of developing a cancer is really high. And with these mutations, there's an increased risk for multiple different types of cancers. It's not just breast cancer. And the one we worry about a lot is ovarian cancer. And the good news is there are recognizable patterns of these, so we can look at a family and find a specific pattern, and that makes us suspicious, and then we do genetic testing. That's how we make the diagnosis. So this is a little bit busy slide, but I love the genetics of it. It's amazing. For me, it works well because surgeons are kind of black and white. We just like, tell me the answer and then we'll take action. So, but we all have 23 chromosomes from our mother and father. it's amazing technology because we have about 3 billion base pairs. You know, and these, I'll show you a picture of it again, but adenine, thymine, guanosine, and thymine are the 4 nucleic acids, and they all line up in a specific way. And it just takes one of those base pairs to lead to one of these mutations. So, and it can be detected. But the chromosomes code, among other functions, code for proteins. And how many of you remember this from biology? So is this all new or sort of slightly remember? And I definitely don't want to go over your head, but I mean, anyway, it's all fascinating stuff, but you don't have to know it. I won't test you. So this just shows you the structure of what the DNA looks like. And again, there are 3 billion of these little things in there. It's just mind-boggling. Basically, Watson and Crick found out about the structure of DNA back in 1953. And then way up in 1990 is when Mary Claire King at UW discovered the BRCA1 gene. And that stands for breast cancer, BRCA, BRCA1. And that was the first one discovered. So on chromosome 17. And then 1 year later, in 1991, they discovered the BRCA2 gene. These are just, the BRCA1 and BRCA2 are just locations. It's a gene location. But within that location, there can be these mutations that are then passed down and inherited. So in 1994, Myriad Lab patented a technique to be able to actually make it commercially available. So they were able to do this test. And that's when modern genetic testing took over. And then in 2013, Myriad lost their patent. They basically were no longer able to say, we're the only one that does this. And so other labs came along and started testing, and now there are a number of different labs that do the testing. Now with BRCA1 and BRCA2, there are very high risks for lifetime risks for breast cancer or secondary primary breast cancer after successful treatment of the first, and then ovarian cancer also. Risk for prostate cancer in males is much higher, and especially it's a more aggressive type and tends to spread more rapidly. There can also be risk for pancreatic cancer in some families. This really, as I'm kind of wrapping up, I just wanted to show you a few slides of families. And so for me, a pedigree is kind of like an EKG for a cardiologist, because I can read it, okay, I read that family. So I'm just going to kind of highlight for you what the pertinent things are here. But these are actually my patients. These are real people that I've just seen recently. So the circles are females and the squares are males. And these are a couple and they have a son, okay? And this arrow means that this person is one that came first into my practice in this family. So I create this, there's a software product that's free, I love it. And I can just do this on the fly and change it, and but it really helps visually. This person's mom, okay, does everybody follow that so far? So this is her mom right there, and these are her brothers. She has a brother there, brother there, brother there, and a brother there, and they all have children, okay? And her mom died at age 77 of ovarian cancer. And she's German, she's non-Ashkenazi, and she's BRCA1. She has a BRCA1 mutation. So BRCA1, of all of the ones we have, has the highest risk for breast cancer. It's about 87% lifetime risk for breast cancer, and up to about 44%, even range as high as 60% risk for ovarian cancer. And we can't really screen very well for ovarian cancer. So this patient actually did genetic testing, and of this mom who's BRCA1 positive, each of her children would have a 50% chance of having the same mutation. So She was tested and she was negative. So she's a true negative. So that means that the ovarian cancer that her mom and her aunt had, she will never have to face, because that's a rare cancer, and that was because of the BRCA1 mutation. But you can see that her brother, Brian, is BRCA1 positive, and there's a daughter and a son there. They both will need to test. But look at all these other impacted people, because sister had BRCA1, this one had ovarian cancer at age 40 and died at 46, never tested. But this one, you know, all of these other people would have a chance of having that BRCA1 mutation. So the whole purpose and rationale for our clinic is to have all of our doctors understand these patterns and send them to me so we can do appropriate testing, so we can warn these people, boy, you need to be tested. And I'll explain to you what we do if we find out they're positive in just a minute. Here's another BRCA1 family. This is a patient that came in to me at age 46 with a really bad tumor, triple negative cancer, which is a very aggressive tumor. And she actually came into my office and found out literally at the point of my visit with her that she had cancer, because she had had a biopsy and I just got the result right before she came in. She said, "You're going to tell me I don't have cancer." And I said, we need to talk. So, but the thing about it is that it was not surprising to me that she might have developed an early age aggressive cancer, because that's how BRCA1s are. They tend to develop very young, they tend to be very aggressive. Her sister had had breast cancer at age 24 and died of breast cancer. Her mom had bilateral breast cancer at 54, her aunt had breast cancer, her other aunt had breast cancer, her other aunt had a daughter with breast cancer, had a granddaughter with breast cancer at 35, another granddaughter with breast cancer at 34. And all of these other people are at risk, okay? Because with BRCA1, if you're positive, then every first degree relative has a 50% chance. So anyway, what my strategy is with this patient is to see her back periodically and really encourage her, try to keep getting the word out, try to let your family members know. It's life-saving. So this is another patient that I just saw who's, she was 35 when she came in with her diagnosis, and she's BRCA2 positive. And BRCA2 is right behind BRCA1. It has super high risk for breast cancer. It's about 84%, about 27% lifetime risk for ovarian cancer. But hopefully you can kind of track with me on this. Her dad has 11 siblings in the Philippines, and it's clear that the BRCA2 mutation came from dad, because both of his sisters had breast cancer. One of her daughters had breast cancer in her 40s. This one had breast cancer in the 50s and ovarian cancer in the 40s. And that's a lot of people. So I've been trying to encourage her to go on and test those other family members, and we're working on that. So the thing that's really encouraging to me about it is just that we can do something about it if we find these mutations. And what I love is to do the prevention side. And so on the prevention side, if we know somebody has one of these high-risk mutations, we start screening really early. So we start doing an annual MRI at age 25. We start doing annual mammogram and MRI at age 30. We can, at age 30, do a variant screening, although it's not that effective, but we can do pelvic ultrasound and CA-125. Generally, for these high-risk ovarian cancer genes, we recommend prophylactic removal of the tubes and ovaries by age 40 or after completion of childbearing. So for men, we screen for prostate cancer at an earlier age. For families where there's pancreatic cancer in the family, we do get them involved in multidisciplinary research area settings to do pancreatic screening, and then we screen for other cancers. So the final thing, just to kind of wrap up, is just that this is another area that's really neglected, that's not well known or heard of, something called Lynch Syndrome. And I think it will probably take another Angelina Jolie in the Lynch world to kind of start waking people up about that. But the prevalence of a Lynch syndrome gene is just as prevalent in the population as a BRCA gene. How do I turn this? Sorry, I didn't mean to shine that into my slide eyes. But Lynch syndrome accounts for about 3 to 5% of colon cancers. And it also can markedly increase risk for other cancers like uterine, ovarian, brain, stomach, prostate for men, pancreatic. So these are, again, just some more families to just highlight. This is a Lynch syndrome family that usually with these, because they're autosomal dominant, you see a multi-generational effect. You see cancers among my grandparents and my aunts and uncles and sisters and brothers, and it just keeps going. And so what the goal is to, if we know there's a Lynch syndrome, we test all the other close blood relatives for that specific mutation. And if they have that mutation, we put them on a really appropriate screening protocol, and it is life-saving. And for Lynch, basically, they actually need to start with annual colonoscopy starting at age 20. And that's life-saving because you can develop these really early colon cancers in that setting. Another family, I won't go through all the details. There are future directions for genetics. And so where we are right now is basically wanting to be really robust in screening and asking the question, could your family have a mutation? Because again, the thing about these mutations is they're stable mutations and they keep getting passed down. And so we want to identify that as high as we can in the family so that we prevent these tragic things from happening. So that's the goal. We are getting to a point now where we may ultimately, because the cost is dropping on genetic testing, where we may actually get to a point where there's just universal screening. And so basically every cancer patient will get a test to see if they have a genetic risk. That could happen. The other thing that's really exciting is they have actually sequenced the whole human genome. So now you can actually test every chromosome and look for everything. And the cost of genomic testing has gone way down, and it's going to continue to go down. And there are already places like Mayo Clinic and some other places where they're doing genomic testing to assess levels of risk, and that's impacting care. So I really envision that probably in the next 5 years, the whole practice of medicine is going to change, that you'll go into the genomics clinic, get your blood drawn, they'll say, well, you're at risk for Alzheimer's, for diabetes, for high blood pressure. You're not really at risk for this or that, and it's going to guide what we do. And I'm excited because we're kind of starting to look at that in the polyclinic in terms of what we might be able to do with that. But stay tuned. So paradigm shifts. I'm excited about that. I hope I'll get to see that at some point. So basically, we covered risks for breast cancer and current screening guidelines and how to recognize patterns for risk, basic principles of preventive therapy, and then evolving aspects. And then finally, just to point out, it's a team approach. You know, it's multidisciplinary, and we're all in this together. The whole purpose of all this is to try to assess risk and not let tragic things happen. So I hope I've helped you understand that a little better. And that's what my whole focus is, if anybody ever has a question or I can help. Okay? Do we have time?
Thank you so much. Maybe we can field a few questions now. I was just thinking, wow, age 20, getting an annual colonoscopy. Now you're never going to complain about your colonoscopy every 10 years again, are you?
That's true.
Every year. So I think we have time, maybe 5 minutes for questions, because we do have another talk right after this. So yes.
Good. Does anybody have any questions?
Oh, I had a question. Does Lynch favor either biological gender, or is it evenly distributed?
Evenly,
Okay.
right. Because it's not linked to the X or the Y.
And for colon screening, would the new occult blood DNA test suffice, or would you recommend colonoscopy?
I'm really not a GI doctor, so, and.
You're
so
talking about the Cologuard,
Right.
which unfortunately has a lot of false positives, so not quite ready
Not yet.
for prime time.
Yes,
I'm just trying to, I may have missed something, so I apologize if this is a bizarre question, but.
that's fine.
So the gene for, or the mutation for breast cancer,
Yes,
that is linked to prostate cancer in men. So if you're looking at your family and there's breast cancer with your mother and prostate cancer with your father, I mean, that's kind of a shared concern. Or if there was just prostate cancer, your father just had prostate cancer, I mean, is that sort of up my mind and thinking?
not necessarily,
Okay.
not necessarily. And we're really looking at multiple cases on one side of the family. So
Okay.
the things that you're really looking for would be multiple family members with prostate cancer, especially if it was metastatic prostate cancer or really high-grade prostate cancer. Multiple family members with breast cancer, early age, so younger than 45 for breast cancer. Ovarian cancer is a big red flag. We actually, one thing to point out is I have some handouts on the back that have a specific screening thing that we're actually using at the polyclinic, that you could, if you go through it and answer it and circle any yes, it looks like this. And we're trying to figure out a way to make it as easy as possible for our doctors to identify this. So if you circle any yes, then that means there could be a risk. So, and I think the other thing too is just if somebody has a doubt, it's always a good idea to just ask.
Actually, I would invite all of you, if you want to fill that out, there's copies back there. Just make sure if you're not my patient, put your primary care doctor down and your phone number so we don't go, who is this? But please feel free to. All right, next, I'm absolutely delighted to welcome our next speaker. And her name is Mary Ellen Shands. She actually works at Cancer Lifeline. She's an RN, has her MN, Master's in Nursing as well. And she's been there for quite a long time in many forms, but her current title is Clinical Program Manager and Family Consultant. And I'm going to pause just for a moment to say that we're going to learn a bit more about Cancer Lifeline, probably through you, but also through our Executive Director, Joseph, after this. So please welcome.
Thank you. So, as Susan said, I am Mary Ellen Shands, and I'm Clinical Program Manager at Cancer Lifeline. I've been there 23 years. I also do research in the UW School of Nursing. I've been there for probably 30-some years, developing and testing programs to support patients and families living with a cancer diagnosis. And I've often said I'm the luckiest nurse in Seattle because I get to help develop nursing science and then use it immediately at Cancer Lifeline. And that doesn't happen too often. I have been providing support in one form or another to families living with cancer for over 40 years now. And to be honest, I cannot imagine any other career where I would be as fulfilled as I am. So things changed a little bit for me last spring when I had my own breast cancer diagnosis, which was kind of very unexpected. And it was early stage. I was very lucky, and I've had my surgery and my treatment. I'm on my long-term hormone treatment now in Mezometa, and I'm doing very well. As I say, I was very lucky. It changed, though, everything for me. And probably the hardest part of this was going from being a caregiver to being a care receiver. It doesn't come easy to those of us who've only known how to provide care to others. And, you know, from the moment I found out that I had cancer, the myriad of things careening through my head about, oh my gosh, how is this going to be for my family? Oh my gosh, what if, you know, what if it is, well, let me give you a little background here. My sister had just found out, it's in December, the previous December, that she, her cancer, her breast cancer was metastatic. And so, of course, I'm thinking, oh, is that going to be my journey? You know, oh my gosh, what about my daughter? So we did, of course, genetic testing. My niece at 46 had just been diagnosed as well. So we did genetic testing. I ended up without BRCA1 or 2, which was interesting. But, of course, we wanted to be sure that my daughter would be getting screened early, and she will be. Any number of things go through your mind. And those of you who've been there know that. You know, you start thinking, okay, why this cancer could be spreading through my body as we sit here waiting for the genetic testing results to come back. You know, what's to say my path isn't going to be like my daughter's, who are my sister's, you know, waking up in the middle of the night, but what if, what if? Okay, those are all the things that we experience, and then I thought, wait a minute. This is what Cancer Lifeline does. We are all about these things. And you know, we are about providing people with information. Let me see if I can advance this here. We're providing a place for people to express feelings without being judged, to feel included and not isolated, and to have a sense of choice and control. Every single thing that we do is built on providing people with a way to meet these needs. Where did these come from, you say? Okay, well, when we first started back in 1973 with just the Lifeline, where people could call and talk to somebody. And then we looked at the call logs, if you will. What were people calling for and what did they need? Everything people needed fell into one or more of these categories. And so we said, okay, we got to meet these needs. So we're going to look a little more closely at these now. What kind of information do people need? Well, you need medical information. It's like, okay, how do I make sense of what the doctor said? I don't understand all those words. I don't understand what this test result really means. What can I do? Cancer Lifeline doesn't provide medical information, but I will tell you, we have some spectacular resources that we can refer people to. We have the Cancer Society, Cancer Information Service. People can call, get their questions answered. The role we feel like we can play there is that we can help people to make that list of questions so that the list is articulate and the questions are articulate, and they will get the answer they're hoping for, and then they can go to their doctor, because their doctor is the person who's going to be able to answer those questions. And it'll be very helpful if everybody's communicating clearly. So that is our role, to help people get ready to go to their doctor and ask those questions. Resources. Wow, any number of people call us for resources. You know, financial resources, and Joseph's going to talk a little bit more about that. Where do I get a wig? I don't have anybody in my family to help me. We have any number of people call us for just a whole list of resources. People call and ask us, you know, my best friend in Alaska just got diagnosed with cancer. What do I say? How do I help? What's the best thing I can do? Should I send her a book? You know, what should I do? So how to be supportive, and that's different for every single one of us, okay? So as we talk about these 4 different areas of needs, if you will, not everybody is an information junkie, and they don't want a whole lot of information. There's other pieces that are more important for some people. So we'll talk some more about that in a minute. But how do you be supportive? What is helpful to that person? And then how do you talk about people? How do I talk to my kids about this? How do I tell them that this has happened. How do I talk to my mom? I just got diagnosed with breast cancer. How do I tell my mother that happened? So those are sort of just snippets of the kinds of information that people call us asking for help with. Okay, this is my favorite need. Because we don't mean to be judgmental, and if anyone asked you if you were judgmental, I guess most people would say, I try really hard not to be. But you know what? We're human beings. We have life experience, and life experience creates judgments in our minds. We can't help that. The trick is that we don't let it come out of our mouths when somebody is telling us something. We're very cautious and careful about our judgments coming out of our mouths. So it happens, but we have to remember everyone's experience is different. And how we would respond to something might not be how somebody else would. What we would find helpful would not be what someone else finds helpful. I think, a really good example of this is, you go to sit down with your family to talk about something that's on your mind. Cancer, okay? Woo! You don't get but 3 words out of your mouth, and everybody has their opinion about what you should do, how you should be reacting, how you should be feeling. And you don't stop and think about the fact that you've just been interrupted. And it comes from caring for you, but it isn't helpful because you don't get to talk and sort. I know I'm a sorter while I talk. When there's stuff on my mind, nope, that's not what I meant. This is really what it is. And that's what helps people really identify what's got them wound up in there. Is being able to sort as they talk. And when we cut that off by giving our opinions or our advice, it isn't helpful. So I'm just going to let you read that. And sometimes, for instance, people might call our Lifeline and say, okay, I need to know where the closest support group is because everyone says, I need to go to a support group. So what do we say? Say, okay, here's where you live and here they are. We say, so tell me what's happening. What's going on? So we really help people tell the story, what their story is. And oftentimes we'll say, so, when you first started talking, you said everyone thinks that you should go to a support group, okay? Well, what do you think about that? Does that feel like that? No, I'm really not a group person, but everybody says I should do this. So it's really not something you really want to do. No, not so much. So what helps you when you're under stress? What is the thing that helps you? Well, I find I'm really good at writing. Writing helps me really process. Well, you know what? There happens to be a writing class that we're holding next week or whatever. So the point there is people will call and ask for something, but unless we give them the space to talk about it, pull it apart, look at it, we might end up helping them to do something that's not really what it is that they need or want, without even realizing it themselves. So really letting people explore their concerns and trying to be as non-judgmental as we can be. So, even in this day and age, cancer is still a very isolating experience. There are still a lot of myths out there about cancer being contagious, about being able to catch it from someone, that it means automatically a death sentence. Lots of that information is still floating around out there. And because of that, people with a diagnosis of cancer can feel very isolated, whether it's from their health, well, those aren't the reasons they get isolated from their healthcare providers. We'll talk about that in a minute. but from in the work environment and sometimes from family and friends, for sure. Those things can exist. Another thing, people don't know what to say to you when they find out you have cancer. And so they don't say anything, and that can be very isolating. I'll come back to work environment in a minute because this is one of the worst places where it happens. Healthcare providers, you say, what? How could you feel isolated from your healthcare providers? Well, depending on how you cope, are you a person who likes to be very involved in decisions about your care? And you realize all of a sudden your doctors, nurses, they aren't getting that. You know, they're just saying, okay, you have an appointment tomorrow morning at 8 o'clock here, and then next week you're going to go, to this clinic, and you're going to have an appointment about this, and you're going to get your blood drawn the following week. Whoa, 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 can we talk about this first, and can I be a part of this? And then you're going to start on this medication. What is the medication? So in many ways, when people aren't a part of the decision-making and aren't brought into that conversation, but the providers are just saying, this is what we're going to do, that can feel very isolating for many people. I think we've come a long way. I think this used to happen a lot more in years gone by. I think providers are very aware now that in our country, anyway, people want to be very involved for the most part. We still have a lot of people that don't and want the doctor to just take control. And then that's a good fit. It's about the best fit for who that person is, which means you have to find out from them, how do you want to work this? Do you like information? Do you want to be a part of the decision making? Those are the important pieces. We do family meetings at Cancer Lifeline, and here's a really good example of how somebody can be isolated from their family. I did a meeting at a patient's home. His daughter, I believe, had called and asked for the meeting. So it was dad, who was a cancer patient, his wife, and I think 3 or 4 daughters, and myself. And when I got to the home, he was on the couch, big man, tall man, probably about as tall as you are, on the couch, facing the back of the couch, laying down, and he never moved the whole time. And we're all in a semicircle around the couch. And as we do in a family meeting, we give everybody an opportunity to talk about what's in their heart and in their head, uninterrupted by the other family members. So we did that, and then it was his turn. And he just slowly turned around, sat up, put his feet on the ground, and just said, I love all of you so much. But for God's sake, leave me alone. I know what I want to eat. I know when I want to eat. I know if I want to get dressed. I know when I want to take a shower. In their efforts to be the absolute best caregivers that they could be, they had taken everything away from him. And there was this giant hole. They weren't communicating. They had isolated from each other. So you never know. You just never know where that isolation is going to come in. The work environment is, people in your family and your friends don't know how to talk to you or what to say to you. Work is really a place where that can happen a lot. And people can feel isolated. Again, don't know what to say, frightened. Am I going to say the wrong thing? Am I going to do the wrong thing? Am I going to catch this? So, just keep in mind that this is very isolating for many people. And then we just have to keep checking in and not assuming that we know what somebody's experience is. Because the minute we flip that and we're making a lot of assumptions, there goes escalation again, back into action. So this is kind of the big umbrella that I think everything falls under. Is cancer not just a giant metaphor for being out of control, because it is cells growing out of control, correct? Once you hear those words from your doctor, you have cancer, everything in your life changes and shifts. You're suddenly not in control anymore. You've got appointments all over the place, doctor's visits, tests. drugs you're taking, people don't know how to talk to you, everything shifts and changes. So, physiologically, your body, you can't depend on it anymore. You thought you could, and look what it did to you. Day-to-day lifestyle changes. I'll tell you, I had early stage breast cancer. But it was like 2 weeks of my life was not my own, of constantly going for this test, that test, doing this, doing that. It's like, whoa. And then, of course, loss of independence. That just comes with it, because that man I was describing, he lost all of his ability to care for himself and do things for himself. So that's a part of it. And when people are quite ill, that's very powerful, because they physically cannot do what they used to do, and that has a strong impact on your sense of choice and control. And then, of course, mortality. You don't have any sense, it's in your face. It's just in your face, and you can't get away from it. Oh, why did I put this slide? Okay. And this is just a summary then. So everything we do is designed to meet those 4 needs. Our Lifeline, if you remember nothing else about Cancer Lifeline, that's how you can get a hold of us, and I call the Lifeline the keys to the kingdom, because you can find out about everything else that we do from there by calling the Lifeline. And Joseph's going to talk to you some more about it.
Just always so moved by those kind of stories, and whether it's cancer or a chronic illness or a medical condition or an accident or an injury, it humbles you. It changes a lot of things when you weren't ready to change. And I think it connects us in so many ways, because we realize that we're all sharing this journey. It's really profound in many ways. So we just have a few minutes left, or however long you want. Joseph Yurgovich is the Executive Director for Cancer Lifeline. I'm delighted he could be here with us to just share a few thoughts and words. Take it away, Joseph.
Thank you. Well, I'll be brief. I just wanted to, and feel free to keep standing or walk around wherever you want to do. I just wanted to kind of segue from what Mary Ellen shared with us, which shapes all of what Cancer Lifeline does, the 4 needs, and how that's changed for Cancer Lifeline over the years. Of course, the Lifeline, as she said, is the first point of reaching out to Cancer Lifeline. It's also a great way to continue to get support. On the Lifeline, we offer people ongoing appointments. So it's we follow an active listening model. And so we have many clients who call and they speak to somebody on our line every week while they're going through a particularly stressful part of their cancer journey. And I just want to say from the onset, our services are open to anyone affected by cancer. And that's a really large group of individuals. So we're not pre-screening people out of the mix. If you have a friend you want to talk about, you're welcome to call. A family member, if you personally had a diagnosis, of course. But the people we serve for free, it's a pretty loose system, and people have been really great about not taking advantage of it. And the Lifeline is just a wonderful place to call anytime you just need to get a reassuring voice, or maybe you want some help on how to have your next doctor's appointment, as Marianne said. The Lifeline, we've expanded recently to do a Lifeline online that allows us to capture other folks who like to use instant messaging as a communication tool. It's not me, but I'm getting used to it. But it's a wonderful service. So people who don't want to talk on the phone and want to reach out to us that way, they can do that by finding the Lifeline online link on our website. I mentioned the ongoing emotional support that people can receive on the Lifeline. We also do some really unique meetings with couples, family meetings, parenting meetings, where we bring together family members. We all don't necessarily have the most functional communication systems with our families. You throw in a life-threatening disease on top of that, and you can watch a slight dysfunctional communication style really spiral out of control. So sometimes it's really effective to bring all the parties together and sit down with one of our clinical program managers and work out a good communication system for how the family is going to deal with the cancer and how people can support one another best. And as well as offering those services, we offer a great unique program called the Therapist Referral Program. I heard from so many people nowadays, it's harder and harder to find a therapist out in the community, and the people that we're serving want to find a therapist who's comfortable talking to people about a life-threatening illness and has experience there. So that's another service we provide for free. You, of course, work out the therapist payment with a therapist that you reach, but we'll give people 3 different choices to reach out that will hopefully match with their insurance and the location they're willing to travel. And then we get into some of our in-person services, more of our in-person services. Of course, Mary Ellen mentioned the support group program. Really proud to say Mary Ellen is the supervisor of our support group program. In all of our support groups, we run professionally. So we have a professionally facilitated group that has rules and policies to make sure that we avoid things that often set groups back a few paces. Things like making sure people follow group rules of not monopolizing the conversation too long, making sure each person gets a chance to check in the group. Those are some key factors. We've got over 24 support groups now.
Meetings a month.
Yes, 24 meetings a month. We also do a lot of classes. Again, this goes back to the 4 needs and empowering people with choice and control, information. Our classes range from creative expression classes, such as it can be from a simple crafts class to a more therapeutic process-oriented writing program. We do gentle exercise classes to help people get back in action after they've had a surgery and treatment, as well as doing nutrition demonstration classes, which is a really fun class. It's a great way to learn, to watch people cook and see how simple they can focus the meals on, and get to sample what we're doing as well. Nothing changes behavior like that, which I'm sure you know if you're working with Dr. Baumgaertel on the Menu for Change program. We also do stress management programs, which more and more we're learning that the importance of controlling our stress in our lives. It's unavoidable, but how we deal with that is not, and we can really make some progress. We also do general information classes, whether it's addressing fears of recurrence, vitamins and supplements while you're in treatment, medical marijuana and the impacts there, acupuncture and acupressure, how it can help, and those are just a few examples of what we do. We offer services both by phone, obviously with the Lifeline, but we do a lot of in-person services at 7 different locations now in the greater Seattle area. So you can find Cancer Lifeline at Evergreen Health in Kirkland, at Overlake in Bellevue, Northwest Hospital, UW Northwest Hospital in North Seattle, the Seattle Proton Therapy Center, Valley Medical Center down in Renton. Virginia Mason will be starting programs in February with Cancer Lifeline. That will be both at the Pill Hill location and at Federal Way. And then we have our center, where we also do some limited programming. You can go to any of those programs or programs at any of those sites. You don't have to be a patient at those sites to take advantage of our free programs there. So in the back of the room, there are these catalogs that have a little bit more detail of what we have to offer, and I hope you'll take some time to look through those. If not for yourself, then as a resource for friends and family. You're welcome to reach out to any of us, and again, if you remember the Lifeline number, that's the key. It's on our website. We're at cancerlifeline.org. And I think I covered all of it, except for I didn't talk about our financial services. We do financial services and support for low-income patients. We offer one-time awards to patients, no matter what type of cancer they have, if they're low income and they qualify. These awards can make the difference between even people in with their electricity on, with food in their kitchen while they've got cancer. A lot of times the bills that we have, even if we have great insurance, the co-pays and the frequent trips to the doctors really can set people back. So those programs are really vital, and we also offer extra financial support information and resources and direct people out into the community and other resources. So that about wraps up all of what we do. It's a lot, and we're very proud. We've been doing it for 45 years here in the greater Seattle area. And now I'd like to take any questions you might have.
So I've been involved with Cancer Lifeline for many years and actually stepped up to join the board. I'm one of the newer board members, although we're getting more as we talk early this year. It's just been a wonderful group of inspiring people, and really the level of services that they offer are just hard to believe in this era. Free.
Since you're free, where does the funding come from?
I was going to ask that.
That's a great question. Well, we do apply for grants where possible. We rely heavily on local donations from our community. I think that drives about, what percentage, about 60% of our funds. The hospitals where we provide programming, we do a contract with the hospitals, and so they do some fee-for-service payments to the organization because they've learned that it really improves their patient outcomes and the satisfaction of their patient's experience at their particular cancer center. So they'll also help support the programs.
Okay.
Yeah.
We have a breakfast in March coming up that I'm involved with. It's going to be at the conference center downtown. What's it called again?
Bell Harbor.
Bell Harbor, that's right. It's going to be wonderful. In the morning, if you're an early bird, great way to have breakfast and donate. I'm really honored to donate.
Yeah, we always look forward to additional support. Anything else? Well, thank you so much for being here and for taking the time to hear about our organization and about the wonderful information that Dr. Smith provided. It was very, very interesting and informative evening, I hope.
Have a great, safe trip home, and stick around if you want to ask questions, but great to see you all. Thank you.